of the session, I'd like to invite with great pleasure one of my very close friends and teachers, Professor Dr. Rohit Shetty, who apart from being the chairman at the Narayan Netralaya group of eye hospitals, has so many accolades that it will take one half an IC to finish it. But in short, he's a clinical scientist and he is a PhD, and he's made so many doctors do PhDs in their areas of interest. So we would love to hear your innovations in refractive surgeries.
Thank you, Samresh. My talk today is on innovation in refractive surgery. These are my financial interests. So if you're looking at today the 10 commandments of a very good LASIK practice, it starts with a very robust diagnosis and it ends with great skill transfer. And what is interesting here as we move on is a good symbiosis between a machine and the diagnosis. So when you're looking at the newer diagnosis, we have options of biomechanics, the epithelium, the stromal imaging, and also the future diagnostics is going to be driven by the genetics in the cornea. The most interesting new device which has come is the MS39, which is a hybrid topographer OCT. One of the advantages of it helps to understand the way epithelium is mapped, the way the stroma is, stromal elevation is, which is minus your epithelium. This is just a comparison of the current generation topographers, OCT machines. What's interesting here is the new generation, which is coming up even as we speak today, is the pentagram OCT, where your axial resolution is getting better and better. So there's a day will come when we'll probably be seeing a sub 1 micron resolution, which will look at the cellular structures without need for any contact in intervention. We look at epithelial maps. This is how you compare. The Solix has the best epithelial maps in terms of giving a 10 millimeters. The Pentacam OCT also, but MS39 is great in OCT, but still limited with 8 millimeters in its entire corneal plane. So the next generation of refractive is trying to see the unseen. For example, you are able to map the Baumann's, and you're also looking at different levels of epithelium. For example, this is your Baumann's, and this is your basal epithelial cells, and this is your superficial cells. So you, at this dimension of imaging, you are able to look at directly, even making 3 levels of classification of your epithelial cells. And what is interesting is when you look at the epithelial cells in this level, and you also look at other imaging, it completely changes the dimension of refractive surgery. Then comes more innovations in trying to see what is hidden using the polarization OCTs. The corneal biomechanics, we have now the role of Corvus. And there is also, there was little interest in the Brillion. We do have a Brillion microscopy, but very, very moody and erratic technology at this point of time. But eventually, I think it will reach a stage where it can be a point of care to the practice. This is imaging of your collagen. The collagen does not show a birefringence properties. So that means whatever light goes in, the polarized lights, when it does not have a birefringence, it picks up as a dark blue, and your peripheral fibers are anchoring fibers, and that picks up as red because that's where you start showing those anchoring fibers are oriented differently. But in this case, if you look at this, there is a loss of birefringence, the loss of orientation of your collagen, so that you can change in the shape, and this is matching to what your biomechanics is. The future is going to be not looking at the topography, which is just an imaging of your surface. It's about the cellular structure. When it comes to innovation in refractive surgeries, this is a roadmap I've used from Halcon platform, where they started with, most of the companies have similar kind of platforms. Started with wavefront guided, and most of them are now trying to look into more customization. Many machines are moving towards ray tracings, and one of the areas of ray tracing in non-lenticular is InnoWise, where Wavelight Plus, they use different names, but now this is what it is. It looks at a complete wavefront analysis from a ray tracing point of view, and then makes your own model of eye where you can plan your refractive procedures. Uh, there are various advantages. Many machines now look at epithelial remodeling as one of the factors. But again, these are all things which is evolving. We need to study, we need to know. Epithelial remodeling is not as simple as optics. Biology is involved in it. So when you claim that it is doing it, we have to understand the biology may have a different answers to it. And this is platforms. I'm sure there are a lot of things will be discussed over time. So one of the new things which I've been using the last few months is again one more ray tracing from a completely different platform called IWIS, where it looks at different levels of measurement, and what it does is it uses different light conditions to measure the pupil size, and then your ablation zone is based on the pupil size based on 8 different light conditions. And this is how a complex cornea's ray tracing is done. The ray tracing has to happen from your epithelial level. So your epithelium and how the ray tracing refractive index changes, refractive gradient changes, your anterior, posterior and total, and then how it reaches your retinal surface. So ray tracing is something very new and exciting, but we have to understand that it has to be done in a proper way. It's like AI, and if it's not done and if it's just a simple extrapolation of data, then it will probably not work. And this is exactly how an epithelial map has a ray tracing epithelial map compared to, that means it's the component of it, how much of it is involved in this process. And it uses a completely different form of ablation zone based on your pupil size, and also it's also heavily dependent on your ray tracing of your epithelium. And you can have a different zones, different customized zones, and creates an ideal shape. And each one of your corneas, and this is fantastic for when you're looking at a very abrated and irregular type of corneas. Then we have the excimal platform from Schwind, which looks at again a different aberration-free corneal wavefront. There's a heavy insight into the presbyopia lasers, and this talk I'll be giving it later. There's already been talks about the small incision lenticule procedures, so I'll just skip. I think a lot of this is going to be dependent heavily on the future is about the lasers, energy, spot size, the optics of it, and every company is trying to integrate beautiful diagnostic machines. I think that is what going to be the next innovation, how you integrate your diagnostics to the laser, lenticule laser procedures. People are working on shapes. Shapes will have a huge impact in the way your aberrations will be neutralized, or you create a presbyopic lenticule platforms over time. And this is a work we did with different lenticule shape and geometry out there. It is also important to understand in today's context the power of immune profiling, because immune profiling it's like whatever kind of surgery you do, your biology, if it's not well, then your healing becomes a challenge. So one of the major reasons why patients come to you unhappy is not your refractive surgery or cataract surgeries anymore. It's because there is an altered immune mechanism, whether it's your dry eye, whether it's in your anterior chamber. So the role of point of care kits, which we've been speaking about, will probably have a huge role in predicting different types of outcomes, like for example haze, the edema healing, and every aspect of your healing can be predicted. And we are getting into a new dimension. Me and Professor Ganesh, we always been discussing about the role of Smile Extra and of strengthening the corneas. And many times we have a challenge. We use our decision heavily is based on your topographies, and sometimes we may be right and we may not be right to do the procedures. But ultimately, it has to be dependent on how good is your collagen. So one of the areas of work we have been doing, I mean, this is a little complicated, like how you do an FNSE. Like, I should just take a minute more. So what we do is, how do you do an FNSE is you take a sample, send it to your lab, and they measure the FNAC and they tell you whether you have a tumor or not. So what we are trying to attempt here is, this is still a cumbersome one, we should do it before the procedure. You take a lenticule, send it, analyze the lysyl oxidase and collagen, and if your lysyl oxidase and collagen is there, after some time, sometimes you can decide if your lysyl oxidase is lower, then you can actually consider doing a cross-linking later, maybe a day or two later. But if you make this process faster, then probably we can decide immediately whether we need to do a cross-linking or not. This would probably be a big game changer in the process. To summarize, we are moving out of topographers alone. Epithelial maps have a huge role, especially in today's context. What I feel is next generation of ultra high resolution OCTs will look at the Bowman's and collagen better. CLEX is going to stay. Only thing is the newer versions of CLEX procedures in terms of the energies, the shaping and what it does. Customized lasers will also have a parallel role because every company is designing customized lasers. I think ray tracing is one area of work. Maybe tomorrow we might have something different. And most important thing in 2025 and beyond is how you understand the immunologies and how you understand the cellular status of the eye, because that determines how your outcome is going to be. And thank you.
Thanks a lot, sir. So two key takeaways that I feel from this talk were very important is for most of the people, it's so difficult to go into the trade and find the machine. You know, and I mean, I think the onus falls on few people to be able to tell us which machine is doing what good and what bad and what it doesn't do. And it's talks like these where you come to know, which, you know, and tend to make up your mind on what to get. The second very important thing that I've come to realize more and more is, you know, to look at the patient as a whole and not look at the eye. There's a lot of times I've burned my fingers, and every time I listen to your talk, I go back with the knowledge, but it'll sort of drift away in a few days, and I'll start zoning back into the eye and not the patient. But picking up and trying to avoid complications by doing immune assays, by looking at the genetic profile of patients and so on and so forth may play a very huge role in times to come, as I can see very evidently from your presentation.
See, if you look at in your own practice, all of you here have a very good premium practice. What makes them to come back again and again to your clinic? It's not your lasers anymore. It's not a complication of your cataracts anymore. It's your dry eye, it's your pain, it's your phantom symptoms, it's your nociceptive symptoms. We did evaluate our own thing. 68% of them come only because they have nociceptive driven factors. And nociceptive driven factors, whatever procedures you do, are not driven by directly by your surgical technique or a machine. So that means that there is a huge way of what we are missing in our diagnostic capacity as, you know, trying to understand it. And today, because everybody goes back into the same, you know, computers, TV and all that stuff. So I feel more and more when all the procedures today, whether you're looking at the ray tracing, whether you're looking at InnoVice or SWIND or any of this, they assume that the healing of your epithelium and stroma is on a particular, they have a standard way of how they assume. The assumption is based on a normal healing, which is there in published literature maybe 10 or 15 years back. But what happens when you're healing is the healing in a contact lens wearer is different. The healing in a thyroid patient is different. The healing in these patients are different. So when you have a healing which is different, 10 microns of it will offset every ray tracing asphericity which you want to create. 2 microns of 6 microns of inferior superior change will offset any kind of EDOF lens you put. So ultimately, whatever you assume is an assumption hypothesis. And assumption hypothesis does not take into account of your individual biology. Your customization of IOL is based on individual biometry, but your biology is not under your control. So that is why I think we're still going to have challenges with this, and it's going to increase. The baby boomers who are going to come and get cataracts are going to be a different lifestyle compared to our parents and grandparents, where the lifestyle is completely different. So our whole dimensions will change over
and also
time.
the fact sometimes you get to, at least if nothing else, tell the patient where the problem is. You may not have a solution, but half the time they're coming into your clinic and you're just changing medicines after medicines. They want to know what the problem is, and sometimes, just a, confirmation that your D3 is low, your B12 is low, or you have lipid glands missing out is enough for them to understand that it's not something that we have done, or it's, at least there is a closure to the whole
See,
problem.
Dr. Audrey is here. Today's major challenge is nociception. Nociceptive factors being increased. You yourself, when we were there, when you have challenges looking at the sunlight, you
Yes.
feel that you cannot, because it starts watering. The nociception is what makes you, all the people who write on Google review about you, which is things have gone wrong. If you really look at that, you will see 85% of them have an exaggerated nociception. Today's younger generation has nociceptive issues which is not managed by your drugs. Steroids don't change nociception. And because the nociceptive ion channels are not changed by steroids. So until unless you all as leaders in cornea thing look at nociceptive factors, the next generation of medicines, Alcon is coming out with a new dry eye drug, it increases the TRPM8. That is, increase the nociceptive factors. So I feel we are changing the way we are going to manage these diseases.